जी, अस्सलाम वालेकुम everyone. Quickly land here and now I'm talking. So bear with me, inshallah. Hope we all be. ऐसे रहेगी लॉन्च नहीं होता. ठीक. All right. Sorry. So just a little further to Dr. Ahmed's talk. He very nicely enlightened and discussed about how to differentiate between difficult to treat versus complex to manage. And this is one of the very tricky, one of the very difficult one to talk. तो मेरा टॉपिक एग्जैक्टली ऑन द सेम लाइन सो इट्स गोइंग टू बी लिटिल ड्राई बट आई ट्राई कि इस पे ज़्यादा बात ना करूँ फ्यू स्लाइड्स ऑन द टॉपिक दैट आई हैव बीन sort of assigned and then talk a little bit about what we know, especially the recent evidence. So the first one is, again, how to differentiate between difficult to treat versus complex to manage. And we have recent like consensus statements around the same, but I'll be talking and more discussing about what the evidence, especially from the recent EULR. I don't know how many of you guys have been there. I didn't go, but I was absolutely delighted to have some of those nice abstracts and especially the oral presentation from my centers, which were presented that I'll be discussing. So let's talk about what first things first. What is psoriatic arthritis? I know we all know what it is. We know that initially it always used to be thought that compared to rheumatoid arthritis, it's a mild enough disease, it's a very smoldering disease. We know there's a very heterogeneous disease compared to, of course, the standard rheumatoid arthritis that what we deal with. So that's why there was a lot of myths about this as well, that it waxes and wanes. We know about that sometimes it can be monoarthritis, oligoarthritis, and of course, sometimes it can be just a spinal alone disease. So that's why there's a lot of diagnostic delays, we all know. I mean, look at the historic, for example, the data that up to 50% of the patient, when they land to a rheumatologist, and then they're being treated, even with the two DMARDs given, still 50% of the patient would end up having new erosions developing. And the Toronto cohort has shown that in their patients, that the first time any psoriatic arthritis patient landing with them, majority of them would have some form of deformities of some form of structural damage already existing in these patients. Means it's not that simple. It's not that simple disease. It's not that early disease. And diagnostic delays, we all know very well. And the prevalence, we know that most of the cohorts have shown prospective cohorts that around 30% of the patients with the skin psoriasis would develop psoriatic arthritis. And the time-wise is different. We all know that. Again, there's a genetic background to that as well. The patient with the HLA 0601, for example, they would develop arthritis roughly around the age, by the delay of 10 years. But the patient with HLA-B27, as Dr. Ahmed was alluding, so those patients with the psoriasis, if they have, they would develop arthritis much, much quicker. Rather from our cohorts, the prospective cohorts, then the Toronto group and the Manchester group have also shown that the HLA-B27 patient actually would develop arthritis first, and then they would develop skin psoriasis afterwards. So that's why there's a little bit of genetic background to who would develop psoriasis first or who would develop arthritis. So as we're going to be talking about the difficult to manage and complex to treat and all this, so there was no consensus as well. So there was all this, as Dr. Ahmed was talking as well, that of course you end up over-treating at the same time because you're about the pain, you're listening to the pain all the time, and of course the patients are not happy, landing in, आप कह रहे हैं सारे joints तो ठीक है, but they're not happy, the family is not happy, they're still in a misery. So that's why we have to have some more consensus statement that what is actually complex to treat and manage. So that's why we know in skin psoriasis and arthritis compared to rheumatoid, compared to axial spondyloarthritis, for example, the patient with the psoriatic arthritis and skin psoriasis, they have had much more psychosocial issues, much more common compared to the other dermatologic condition. And you name it, how many would have. For example, if you look at the bottom one, 60 or rather 70% of those patients with the psoriasis and arthritis would mention having significant impact on their emotional and mental health, right? So that is the impact of the non-inflammatory symptoms in our patient with the psoriatic arthritis. We know that there is literally every year there are new biologics, new sort of these targeted treatments coming, but still the outcome is not the best. Even in the best centers, you talk about the prospective studies I'm talking about, they're roughly less than 50% of the patient, even though we have got the best, for example, the new targeted treatments, less than 50% of the patients are able to achieve the MDA, they're able to achieve only ACR 50. So means the 50% of those patients, we are still struggling to achieve good disease control in these patients. So treatment response, again, as I'm highlighting there, look at those lot of things that can contribute to the poor response in these patients. We know the metabolic factors. We talk about the obesity. There are very nice data on obesity as well that I'll be discussing, and the smoking. Concomitant fibromyalgia, central sensitizations, depression and anxiety, of course, is very, very common in all the rheumatologic conditions. The gender differences, genetic and all this. So there's a very long list if you can start writing all those. These are the important factors that when we talk about having a good disease control, not just the CRP and ESR. And the problem with the psoriatic arthritis is that 50% of the patient would have normal inflammatory markers. Even they would have roaringly, like might be 20 different joints swollen and tender. So that's why it's not that we have a lot of objective evidence. So there are subjective complaints going on, and we are still struggling to have a good biomarkers of inflammation in these patients. So that's why it's very important to spend some time and try to elucidate, try to find out that what could be the other issues not helping us to achieve a remission. बल्कि इससे मुझे याद है, मैं अपने फेलोज को एक बात कहता हूँ, तो विच आई वाज टॉकिंग दिस मॉर्निंग इज वेल, कि फिजिकल हेल्थ तो हम संभाल लेते हैं, लेकिन जब मेंटल हेल्थ खराब होती है, आई एम टॉकिंग अबाउट ऑल ऑफ अस इंक्लूडिंग मी, एंड एग्जैक्टली द सेम थिंग गोज फॉर द पेशेंट्स. हम सिर्फ और सिर्फ उसी पे सिर्फ जॉइंट काउंट्स देख के हम कहते हैं जी हमने बड़ा कुछ कर लिया, but literally I can guarantee you सिर्फ 50 seconds 40 seconds और spend कर लें, just try to talk about two things which I ask every single patient: about their sleep, about their fatigue, and just ask them how fresh they feel. सिर्फ ये तीन चीज़ें मैं हर एक से पूछता हूँ, और लिटरली आप हैरान होते हैं, उसके बाद फिर कई दफ़ा सुननी पड़ती हैं क्योंकि वो स्टोरियाँ शुरू हो जाती हैं. ठीक है, तो ये lot of times these simple things help us rather than just talking about or looking at the joints. So it's very important, as I mentioned, that we really need to be good at finding out actually, is it the treatment refractory, or is it some other issues sort of contributing to that? So Grandpa took that role as regards trying to find out how to come up with a consensus of all those. So the usual, how we start off with the new project, we just come up with the literature review first, what's out there. And then, of course, is the perspective asking to the healthcare professionals and to the patients, like, what do they feel? And then the usual, the Delphi exercise, and come up with so this is the standard of any new thing that you want to come up with. So the first thing they looked at the literature review, and about difficult to treat was not surprising. Of course, if patient is failed with the one biologic or the two biologic, of course, they should be, most of the people would agree that they would be called as difficult to treat. And when they asked about the healthcare professional, so pretty much the complex to manage, and again, there's a lot of the psychosocial issues that they sort of agreed on. Okay, those are the important factors. So now the GRAPPA has come up with this, the umbrella term, if you like, that is complex to manage, right? The difficult treat will come afterward, but these are the patients, like, first of all, finding it out what is complex to manage. And this will encompass all non-inflammatory reasons, psychosocial, emotional, whatever you name it, right? So this is the umbrella term of complex to manage. Do not confuse it with the difficult to treat, right? So this will be inclusive of all those, whatever comorbidities you're talking about, whatever fibromyalgic elements you talk about, right? And the difficult to treat is now what we call treatment refractory. I know this is a little tricky, but because now this is the one that we're going to see in almost all the trials that we're going to come up with, right? Complex to manage versus difficult to treat. So that is how they have little dissected it out, that the complex to, so I remember this is manage means the management principle, and the treat is, of course, when it is treatment refractory. And here you're talking about the objective evidence, the objective elements of what they have, the joint counts, the inflammatory markers, MRI evidence, for example. So there are objective signs of inflammation needs to be there. before we label it as treatment refractory psoriatic arthritis. Again, 2025, GRAPPA finally agreed on those statements, and then exactly the same year, the ULR came up with the similar issue, similar things, exactly the same. I don't know, it's the sixth grade kids fighting on, the EULAR, and the same as with the GRAPPA. So was the GRAPPA was the same when they published guidelines, exactly the same year that the ULR published their guidelines of psoriatic arthritis. Very, very subtle changes, but they make sure that there are some changes. Even the changes could be just a terminology. And here what you exactly see, how these people, I don't know, all these influencers come up with. So is complex to manage, and the other one that talk about difficult to manage. So that is this umbrella term. So again, the ULR come up with this one, and that's very, very sort of specific terminology. So GRAPPA, complex to manage, and that is difficult too. And again, as I mentioned here, it's the same, the inflammatory and non-inflammatory combined together into one, and that is the umbrella term of difficult to manage versus complex to manage. Little very subtle differences when they come up with the difficult to treat or treatment refractory. Here they're talking about, for example, the two failures of the biologics. Here they talk about the one failure of biologic, and then few other things, objective signs. But again, the only one thing which was very, very important, and that is unfortunately GRAPPA lagged, and only one thing was that in the GRAPPA, they did not exclude your comorbidities when they dissected it out about the difficult to manage, or the treatment refractory. So in suitability, so the comorbidities GRAPPA may include, so EULAR have excluded your comorbidities. So that's why in the clinical trials, perhaps the EULAR criteria of difficult to treat, I think it would be more feasible and would be more applicable because they have like excluded the comorbidities. I think we have gone through all this. So this is when I left Ireland. So this is 2017, thereabouts. And imagine the expectations have changed so much. I was just thinking, when I opened my rheumatology eyes back in 2002 in Ireland, you could be amazed that those were the time when the anti-TNF were like sort of coming in place. So we have like most of the patients on infliximab and all this. I remember, of course, I was a senior also. I was just like a junior training and then registrar. So all these patients who were on triple therapy, quadruple therapy, and literally the bosses were happy that this is a disease in remission. वो है ना कि जब ज़ाहिर स्टेट देरी होती है तो बायोलॉजिक्स भी मज़े से यूज़ हो रहे होते हैं. So we used to use then on certain patients who would have, we thought that this is a chronic inactive synovitis, right? And we were thinking like, okay, that's fine. But the moment, at that time, I'm talking about 2002 and 3, but the moment the biologics are given to those patients, वो सारे के सारे जो जिसको हम कहते थे chronic synovial swellings, they would all dissipate. So at that time, I remember what we were taught initially was that the सबसे ज़्यादा expectation, सबसे ज़्यादा आपका जो success है, वो है, which was a rule, not an expectation. क्या था कि deformities होनी है, उनको बचाना है. And means that was a rule, not an exception. I'm talking about at that time when, of course, double therapy, triple therapy, ये सारी therapy. But now क्या है expectation? Now we're talking about 2025, 26 में. Now, how to change the disease, the nature of the disease. कि हमने पहले कब इंटरवेन करना है, कब किस तरह करना है, जो नेचुरल कोर्स ऑफ डिजीज है उसको चेंज कैसे करना है. वी आर नॉट टॉकिंग अबाउट द डिफॉर्मिटीज. सो दैट मच थैंकफुली द साइंस हैज प्रोग्रेस्ड व्हेन इट कम्स टू our rheumatology world. So again, you name it, like literally more and more, all those drugs are coming. The guidelines, the GRAPPA, this is 21. Again, very nicely, all those, the domains that they have been highlighted, how we and the latest one is right now, is in the compilation, the final stage, and hopefully might be published this year or early next year. So we did little exercise as well of this APLAR guideline that we contributed, myself, and also we have a patient partner as well, who was a patient and also was a quite educated, and he participated that as well in writing those guidelines from the patient perspective as well. So let's talk about a little bit about the recent sort of what can we learn sitting here, not in the, of course, our socioeconomic status. And of course, we know the all IL-23 and all those drugs that we talk about. But again, what our settings tell us, what can we learn? अगर हमारे पास, excuse me, access नहीं है सबसे latest drug का, how can we achieve the best? So this is was 25 में यूलार में publish हुई थी, and what they actually came up was कि अगर हम anti-TNF को very earlier on start करें with the good dose of methotrexate with the steroid, so triple therapy, starting with anti-TNF with the methotrexate with the steroids, bang, early disease, compared to just a methotrexate and little steroid. Steroid क्या था, एक short था बस शुरू में, and then try to see कि what actually happens. And of course, इनका ख्याल यही था कि it would lead to very improved outcome and everything be fine. And these disease duration of less than 2 years, our participants, they were started on methotrexate, 15 milligram, right? At week 24, bang, what they actually found out was there was no difference. Absolutely no difference in the outcomes. आपने बेशक anti-TNF दिया from the very outset, from the very day one, with the good dose of methotrexate, with of course background steroids, compared to just the methotrexate alone. No difference, no difference. I'm talking about a randomized control trial. These are not just a cohort study, right? Or again, week 52, mein, the patients are more important. Like 1 year, mein, the patient who were on methotrexate alone arm, they had a better retention. आपको पता है ना, retention हम use करते हैं as an indirect way to look at the disease or the treatment success, okay, that they hold it on to that treatment, right? और बाकी भी सारे outcomes क्या थे? अब इसमें सबसे important क्या चीज़ थी? वो थी कि कितनी जल्दी methotrexate को escalate किया गया. So they were started on 15 milligram day one, and within 4 weeks, the methotrexate dose was escalated to 25 milligram. So 25 milligram within 1 month was escalated compared to your standard anti-TNF, one of the best one. The outcome was very similar. So from our local setting, this is a very important data, right? And there are quite a few other ones as well, but this is, I'm just discussing the latest one, right? Another one. I hope the artist वाले नहीं सुनेंगे इसको. So this was again from the very outset, the early secukinumab was given exactly the same way, right? So early arthritis, very early arthritis, psoriatic arthritis. The first treatment is secukinumab, not the standard 300 milligram. Means like the higher dose जो हम biologic failure के लिए use करते हैं, उन्होंने directly वहीं start की secukinumab, right? Compared to methotrexate. Again, in 6 months' time, ACR of 50 is exactly similar. And again, यहाँ भी क्या था? यहाँ भी exactly this have followed the same. The methotrexate was escalated bang to 25 within a month. So what we do, we all know. हम 2.5 पे लड़ी जा रहे होते हैं. एक महीने बाद 2.5 बढ़ा रहे होते हैं. So that's what it's showing. And this again, a randomized control trial, not a cohort study, as I said. आप इसको जरा थोड़ा सा switch करें और देखेंगे. This is another study, another randomized control, little older, 2022, I think. So again, a randomized control trial of the same the anti-TNF, right? So the methotrexate screen, so randomized and then given Humira injections compared to escalated treatment. लेकिन इसमें अगर हम देखें, the non-responder is like week 16, right? At 4 months time. So 41.5% of the patients achieve remission. लेकिन जो escalated methotrexate जब की गई है, तो यहाँ response नहीं मिला उन्हें. पहले दो में तो बड़ा ज़बरदस्त हमें response मिला. There was no difference in the primary outcome. But here there was a difference. क्या हो सकता? The difference was, sorry. So the difference was that those patients were just kept on 15 milligram a week methotrexate. और अगर किसी को बढ़ाना भी था, was dependent on कि जो भी clinician है, और उसका जो protocol था, that the dose was escalated by 5 milligram every second week. Means the learning for me was that if you really want to go on, stick with the methotrexate, or you're gonna rely, you have to escalate the treatment very, very quick. एक तो पहले यहाँ delay हुआ है कि screening की, randomize किया, methotrexate alone treatment चल रही है, right? So इस treatment में भी there was a lot of time was spent. कि just standards routine की doses use हो रही हैं 10-15 milligram, और यहाँ जाके after I think it was a good few months. So the delay in introducing methotrexate, and especially the delay in escalating the treatment of methotrexate, that was a major issue compared to like if you want to go as regards the biologics or whatever. That's the first thing. Now, talking a little bit about the psoriatic arthritis versus rheumatoid arthritis, we know, like, for example, in the established or with the high disease activity, unfortunately, patients with the psoriatic arthritis, oh, there hogi. Right. So, इसमें less DMARDs, we all know, sorry, thank you. तो कम यूज होती हैं DMARDs, we know that compared to the rheumatoid arthritis, again because of all this. Talking about the combination of the biologic or targeted synthetic DMARDs, if you look at the evidence, for example, all the evidence, all the papers, not the more abstracts, they all come from the first line biologics use compared to second line or the third line biologics. Very much similar, what we see is that if we start with the first biologic, no matter whatever we are going to choose, non-TNF versus TNF versus non-TNF, जो हमारे सबसे अच्छा response होता है वो first biologic से होता है, and then the second and the third one, the efficacy and the response and the remission rates are a lot less with the subsequent visits. And the same another one showing exactly the same. But in skin psoriasis, the response is a little different, if you like. So this is the Foster plot from the systematic reviews and the meta-analysis. And these are box plots. I mean, this is one systematic review, this is another one. So these are 4 different, and this is the forest plot. So what they're showing here is, so this is the treatment effect. So this is the pooled effect, if you like, this is diamond of that particular systematic review. So what it shows in the skin psoriasis is that the treatment is not lost, what we see in psoriatic arthritis. Whether आपकी फर्स्ट लाइन है, सेकंड लाइन है, थर्ड लाइन है, फर्स्ट लाइन से आपको फेलियर हो रहा है, यू मूव ऑन टू द सेकंड वन, तो जब भी आप यूज करते हैं स्किन सोराइसिस, द एक्चुअली ट्रीटमेंट इफेक्ट वुड रिमेन द सेम मोर और लेस. जरा क्विक फास्ट कर रहा हूँ मैं, क्योंकि ये इंपॉर्टेंट चीज़ें हैं जो, और बिकॉज दैट हेल्प अस एज गॉड्स टॉकिंग अबाउट द डिफिकल्ट टू मैनेज एंड ऑल दिस. सो दिस इज अगेन अनदर रैंडमाइज्ड ट्रायल. व्हाट दे लुक्ड एट वाज आपका जो कीटो डाइट है वर्सेस मेडिटेरेनियन डाइट, and both of course led to very much similar rates of the weight loss and their outcomes on ACR50 and MDA. What they found out was that the patients with the keto diet, they ended up having a better outcome, and that was the only one compared to Mediterranean diet जिसमें आपका actually DEPSA भी improve हुआ और PASI भी improve हुआ. So not just the weight loss in this particular trial, not just the weight loss, because the weight loss was quite similar in the both, whether you use Mediterranean diet compared to your keto diet, but the patient who had the keto diet, they had a better PASI score compared to the placebo. They had a better the DAPSA compared to the baseline. So the EULAR में जो हुई हैं, so it was very fascinating if you read the whole PSA, the abstracts presented. क्योंकि हमारी हमेशा लड़ाई ये होती है ड्रग चॉइस, ड्रग चॉइस, ड्रग चॉइस, कब कौन सी देनी है, पहले कौन सी देनी है, बाद में कौन सी देनी है, पहले देनी है कि लेटर ऑन देनी है. So literally it was a very obvious, very, very loud and clear message was that the drug choice matters less. The comorbidities matter the most. और इसमें जो very, very important था was that particular signal कि आपका जो the treatment, जो weight is not is a treatment target. ये कोई comorbidities नहीं है, ये कोई आपकी कोई sort of वैसे नहीं है कि चलो और कुछ नहीं तो ये भी जरा जाते जाते उसको ये भी कह दो कि weight भी कट कर लेना. So that should also be one of your treatment targets, and I'm going to tell you from these ones. So this is the speed trial already published, but they re-looked at the speed trial by these repercussive, the partitioning. This is a machine-like tool where they, just like this हमारा random जो आपका है multivariate analysis होते हैं, इस तरह machine variate में भी different जो variables होते हैं उनको वो screen करते हैं and come up with कि किसका कौन सा impact किसका ज़्यादा है. And what they ended up finding in this particular randomized control trial was, after the machine learning, that the BMI stand the most important predictor of your remission. Number one. और आपका treatment का किस पे आता है? Number 6. कि आपने treatment choose कौन सी की? That came at number 6. So number 1 came your weight, right? Let's fast forward. So this is another one, phase 2, again published in the abstract form. ठीक है जी, इसमें भी what they looked at was आपकी जो IL-17 inhibitor दी गई, दूसरे ग्रुप में IL-17 versus your the weight reduction, the tirzepatide जो आजकल चल रही बड़ी. So जबरदस्त उन्होंने just your IL-17 alone, IL-17 with tirzepatide, and the third one was the placebo. And what they ended up finding was not surprising, ACR 50, of course, weight reduction usme zyada tha. But the patient who had a better, of course, the weight reduction, ACR 50 or minimal disease activity was much, much higher in those patients. So this was the first randomized controlled trial to tell us, पहले तो सारी वो cohort studies चली है ना, सिवाय जो एक दो और थी, लेकिन ये properly drug intervention में what they ended up exactly highlighting what we have seen in the other ones. Right? फिर ये एक डिप्सा ट्रायल है, अगेन टॉकिंग अबाउट कि मेडिटेरियन डाइट है, आपकी लो कैलोरी डाइट है और स्टैंडर्ड, यानी हमारे पास जैसा यूजुअल आता है, पेशेंट आता है, हम उससे डिस्कस कर लिया, उससे वैसे एडवाइस कर दी वे रिड्यूस करो, फिर दूसरा है जी कि आप उसको लो कैलोरी डाइट देते हैं वर्सेस आपका यूजुअल मेडिटेरियन डाइट. तो इस पर्टिकुलर जो एब्स्ट्रैक्ट प्रेजेंट हुआ है लंदन में, व्हाट दे एंडेड अप वाज कि नो मैटर हाउ यू अचीव वेट लॉस, वेदर वो ए से करें, बी से करें, सी से करें, जैसे मर्जी करें, weight reduction करें, and actually you end up having better outcomes, better clinical hardcore outcomes. Comparison, and another one very good one as well, just highlighting, we all talk about IL-23, of course, because 1 in 3 months is zabardast aram se ek injection compared to IL-17. So this was the first direct head-to-head comparison, and IL-17 came superior to IL-23 when it came to, of course, psoriasis and psoriatic arthritis alone. This combo trial abhi nahi hai, abhi they just presented at this particular EULAR. Just wo hota na jo typical wo highlight karte hain ki that's what they're going to be inducting the patients. This one would be the major breakthrough when they're combining JAK inhibitors versus your biologics. Ab jaayega to then would be very interested to see. Combine to khair hum kar rahe hain, frankly main to kar raha hu abhi bhi, because there are a lot of data behind it, but this would be the randomized control trial. So let's wait for that. That's my part. Thank you.
Thank you, sir. Thank you so much. Our next presenter is Dr. Samina Ghaznavi. She is working as a consultant rheumatologist at South City Hospital and DHA Medical Center.